would you please welcome Dr. Amy Hayden?
Thank you so much for that introduction, Julie. Julie is just a fantastic ambassador for cancer treatment, cancer patients in general, and also radiotherapy as a treatment which she went through. Thank you very much for that introduction. I have to say, my husband also finds all the acronyms quite amusing, and when I'm off to a meeting, he's always saying, is it TROG or is it FROG or is it ANZUP, and which one are you going to this time? So I'm a proud FROGger, which is the Radiation Special Interest Group for the Management of Prostate and Other Genitourinary Cancers. Now, often at the beginning of a talk these days, we're usually supposed to give our disclosures or conflicts of interest. Now, I don't have that in my presentation, so my disclosure today is that I live in Coogee and I think the Eastern Suburbs beach is the best, and that I'm a middle child and I was a bit starved for attention, so once I get started, sometimes I don't stop. So I've been told Julie will be cracking the whip if I run over time. So I'm going to talk about management of prostate cancer, and I'd very much like to thank Jeff and Tony for the invitation to talk. It's fantastic to have Jeff join the PCFA, and as the clinicians involved in treating prostate cancer, he's been amazing to get to know and work with over the last 6 months. And thank you to everyone in the audience for turning up today. It's wonderful to see such a great turnout, and let's get going. So Jeff's given me a hard job to talk about management of prostate cancer in half an hour. So it's not comprehensive, it's a bit of a whistle-stop tour, talking a little bit about where we are now, some of the big changes that have happened over the past couple of years due to clinical trials, and what are some of the things that we're looking at as we look at trials in the future. But I'd like to also ask you to have a think while I'm talking. So if I'm giving a talk here now saying this is the developments that we've made recently and what we're hoping to do, if I was to be invited back in 5 years' time, what would you like to see me talking about? What trials would you like to see happening in prostate cancer? What advances do you want to see? And I think that there'll be some time for some questions at the end. So moving along, as Jeff has already alluded to, we've made some big strides. Things have really improved, and the improvements are quite substantial. So this is some information from the National Australian and New Zealand Prostate Cancer Registry, which is covering quite a significant proportion of the population now, and is prospectively collecting information about men who are undergoing treatment for prostate cancer. And if you have a look at the graphs on the side, which shows you the survival between 5 and 10 years, and what it's improved from the 80s until now. Those are big gains. And as Jeff said, there's recently been a publication showing that Australia is within one of the top 2 countries in survival for prostate cancer. So we're doing really, really well. But we can't rest on our laurels. There are still improvements to be made. As Jeff said, we'd like to get all of those numbers up to 100, but there are also segments or pockets of the community where the outcomes aren't as good as they should be. And that's an area where we also need to try and do better. So for men in regional Australia, for some disadvantaged communities, there are definitely things that we need to work on to try to improve the outcomes in those groups. So let's lift everyone up to the same level as well. When we talk about managing prostate cancer, as a clinician, it's sometimes easy for us to get caught up, for me as a radiation oncologist, to get caught up in the technology and my fancy, big, expensive machines, and as a surgeon to get excited about the latest surgical techniques, and as a medical oncologist to be excited about the latest drugs and chemotherapy and medicines. But there's a lot more to managing prostate cancer than just the actual treatment that is delivered. We also need to think about how the treatment is delivered and what someone might experience as they go through the system. And there's research into improving the patient experience to ensure a more coordinated pathway through the system, to ensure that information is communicated well. A lot of these things are very complex for both doctors to explain and for a patient to understand, and finding ways to give that information clearly and in a way that is meaningful is very important. It's important that we look at quality of care. So you don't want a situation where you're getting very good care for a small segment of the population. You want to make sure that the quality is maintained across the board. And that's one of the big things that is being looked at the moment, is trying to raise the quality of treatment in all sectors. And to do that, we want to measure outcomes. So we want to know what is actually happening and what are the results. And that's where things like the Prostate Cancer Registry has such a great role, by actually telling us how we're doing and telling us where we need to improve. So this just shows some of the areas that we need to think about in addition to the actual treatment, which is why my title for the talk was Management of Prostate Cancer rather than Treatment of Prostate Cancer. And quite a few of these foundations that I've listed down below, some of these things will be addressed by other speakers later today. So when I was thinking about some of the improvements that have been made in the past few years, quite a few of the significant gains have been made not by new or additional treatments, but actually sometimes by giving less treatment or avoiding treatment. And the benefit of that may be avoiding or having less treatment when you don't need it, and avoiding side effects that is associated with that. So it's not always about more and new treatment. So one of the big things is trying to get this balance right. Where's my pointer? Forward next. So we want to avoid or decrease treatment where there's no benefit, where it's not needed. But on the other end of the spectrum, we need to identify the more significant prostate cancers with a higher risk of recurrence so that we can improve outcomes, sometimes by combining treatment or using better treatments, but also with the intent of reducing side effects. So one of the things we need to try and do is to get this balance right. So going back to the beginning, often one of the first things that we talk about is what is the role of PSA testing as a screening test for prostate cancer. And it's a complex and difficult issue, and there's no absolute right or wrong answer. We do have Australian guidelines for how this should be managed, and what these say is that men should be offered the opportunity to consider and discuss both the benefits and the harm of PSA testing with your doctor before making a decision. There are benefits from PSA testing, and there are some big studies, particularly from Europe, which have shown a decrease in prostate cancer mortality by using PSA screening. But the benefits are relatively modest, and there are some harms that come with PSA screening as well. So for an individual person, it's important to consider both the benefits and any of the downsides, and make the decisions that is right for you after discussing it with family, friends, or loved ones. So having a conversation with your GP is the first step, considering the information, and then making the decision that's right for you. And as Tony and Jeff both alluded to, getting good information out about how to make these decisions is really important. And that's why I wanted to give kudos and demonstrate the latest tool that the PCFA has launched on the website, which is a decision aid, or a sort of a structured information set about both the benefits and any downsides of PSA testing. So this is the website address there, and basically it's doing exactly what was just mentioned before, putting the information out there in plain lay language that's easy to understand, to weigh up those pros and cons. So have a look at that one, or if you've got friends or family who are thinking about whether they should or should not, this is a really good starting point. After a PSA test, if that's elevated, often the next step may be an MRI. And this is a change from what used to happen in the past as well. Often after a PSA test, the next step may have been directly going to a biopsy. So one of the changes that has happened over the past sort of 5 years has been the introduction of using an MRI first before proceeding to a biopsy. The word multiparametric you might sometimes see referred to, or MP-MRI, means using different sequences in the MRI. So looking at the prostate in different way, looking at its shape, the blood flow within the prostate, the density of cells within the prostate, to try and use all that information to tell us if there's an abnormality within the prostate and if it's likely or not likely to be prostate cancer. So sometimes when you see an MRI report, it will have a number on it called the PIRAD scale, and that goes from 1 to 5. Now that's not giving a number of a grade of a cancer, it's telling us the likelihood of whether a cancer is there or not, and whether that you then need further testing. So as with PSA testing, MRIs are not perfect. They can have both false positive and false negatives, And that's why usually, not in all circumstances, it will be followed with a prostate biopsy if there was an elevated PSA to prompt the MRI in the first place. There are studies looking at whether or not an MRI can be used to avoid a biopsy if the MRI is negative. There are some promising results from the UK, but that's still something that we're investigating and learning more about. Using an MRI up front to target the area where we can see the abnormality, we know that that increases the likelihood of us finding the significant cancer and avoiding missing cancers. But what we don't know yet is if we can avoid doing the biopsy if the MRI is clear, and that's an area of active research. So the MBS funding for prostate MRI was, I think, introduced last year, and that was after a long effort of lobbying and applications by various bodies. So it's fantastic that that funding was released, and that's now MBS funded for several clinical indications. Now, if anyone's ever had an MRI, it's quite noisy, takes about half an hour, but it does give us good information. So this is the next step of where things might head to with MRIs of the prostate. So at the moment, a radiologist will look at the MRI and give us a report and a PIRAD score to tell us whether or not they think that there might be a prostate cancer there or not. The next step is actually to take this to an even more sophisticated level, and this is called radiomics. And this is looking at all the different features that you might see in a picture, not necessarily always visible to the human eye, but if you put these MRI images through a computer system, combine that with information from pathology from a prostatectomies, correlate the two and use something called deep machine learning, which is where a computer is able to pull out thousands of data points and compare the two, it can come up with some predictive models in terms of detecting where a prostate cancer might be and the likelihood that it's there. So there's a lot of work going into radiomics. We're doing some research at Westmead with our medical physicists, but there are also very, very big players getting involved in this. Google and Johnson & Johnson have just formed a partnership in the US, so you've got the biggest technology company in the world, one of the biggest healthcare company in the world, and they're trying to look at how we can use artificial intelligence to optimise delivery of healthcare. And this is really just one example. So in this is a slide from Annette Harworth, who's a medical physicist that I work with at Westmead, and this has used a model from imaging pathology to predict where the cancer is, and you can see that the blue is where we've predicted it, and the green line is where it actually was when they looked at it under the microscope. And the match-up is actually pretty good. So that was coming through a computer. This is also something that we're also quite excited about in radiation therapy, because if we have very good imaging telling us exactly where the cancer is, we can improve our accuracy even more to improve outcomes for treating the cancer. But defining the location is just really a bit of a tip of the iceberg, as with many things. There's so many other things that we want to know about the cancer so that we can customise treatment for it. And so what my colleague Annette has been looking at, so we can look at the location. They can actually now predict the cell density, and sometimes this can be a marker of grade of the tumour. And we're also making some steps in terms of predicting the tumour grade. Oh. Okay. Can everyone up the back hear me? Good, thank you very much. What's my timing? So this is an exciting area of research. Now, prostate cancer is not one disease. It's a huge spectrum, and I think that that makes it really challenging for us as clinicians, but also for men with prostate cancer. You get a diagnosis of prostate cancer, what does that mean? Prostate cancer can be very low grade, not life-threatening, unlikely to progress, and never likely to cause problems during someone's lifetime. At the other end of the spectrum, we can have very significant prostate cancer, which is high grade, which may have spread to other parts of the body, which really does need treatment. So it's not one disease, and we really need to customise how we deliver care. So for localised prostate cancer, what we do these days is a risk-adapted approach. So we want to get all the information that we can about the prostate cancer, and that would be information from the biopsy, looking at the Gleason grade or the grade group of the prostate cancer. We want to know what the T stage is, which is how extensive it is or is not within the prostate itself, and what the PSA value was. We want to look at information from the MRI, and we also want to know about the man with prostate cancer. What symptoms does he have? What's his general health like? What do we think his life expectancy might be? And most importantly, we want to know what's important to the man with prostate cancer. What are his preferences and priorities? What's going on in his life? And all of those things are going to come into a discussion with your doctor about what your treatment options might be for localised prostate cancer. So the standard treatment options for localised prostate cancer would be surgery, which is a radical prostatectomy, or radiation therapy. And radiation can be delivered either as external beam radiation, which is given from a machine from outside the body, or it can be given as brachytherapy, which is when radiation is given from inside the body using radioactive seeds which are implanted in the prostate or put in temporarily into the prostate through a needle. For all stages of prostate cancer, most men will often have a choice or more than one option in terms of the treatments for prostate cancer. So in my opinion, I think it's often a good idea to talk to both a urologist who looks after surgery and a radiation oncologist who looks after radiation therapy. Figure out what's important to you and communicate that to your doctor to then work out what's the right decision. But it's a complex decision, it's difficult, and one of the things that Jeff and I and the PCFA are hoping to work on down the track is how we can communicate information about those treatments and the pros and the cons even better. For low-grade prostate cancer, so often prostate cancers with a grade group 1 or Gleason 6, and sometimes Gleason 7, sometimes surveillance or monitoring the prostate cancer may be a better option. Go back. So surveillance is where, I've got another slide coming up for surveillance, so we'll talk about that in a moment. The other important concept in terms of managing localised prostate cancer is that you need to get a team. It really isn't a one-person show anymore, one man or one woman. You want the team, and that involves the person with cancer at the middle, and your GP, your oncologist, your surgeon, the medical oncologist, the cancer nurses who might be involved in your care, physiotherapy, dietitian, psychology, exercise physiology, physiotherapist. All of these health professionals have an important role to play in the delivery of treatment. And what often happens is, as you move through your diagnosis, treatment, survivorship phase, who's important or sort of at the forefront might change a little bit over time. But your GP is a really important person in terms of helping coordinate that team-based approach to care as well. You can also always ask for anyone who's diagnosed with prostate cancer. Many cases are actually discussed at a team conference, which is called a multidisciplinary team meeting, where we might review radiology or pathology. So for a man who's been diagnosed with prostate cancer, or if something has changed with his health, you can often ask your doctor if it can be discussed at the team meeting, where all the results are reviewed and discussed by the group. So coming back to active surveillance, this is in low-risk prostate cancer, which is typically low-grade. What we know is that with PSA screening, we do diagnose a lot of cancers that sometimes don't ever progress. So if it's a low-grade cancer, sometimes monitoring the cancer may be a better way of approaching things rather than having treatment. And with surveillance, it doesn't mean no treatment or nothing happening. It means that we use time to help us work out if this is a cancer which needs treatment or if this is an inactive cancer that doesn't need treatment. So it avoids treatment if it's not necessary, which means that you avoid unnecessary side effects, but it is important that we still monitor things closely, and if there is any evidence of growth, either because the PSA is going up or there is a change in the biopsy, then we go on to active treatment. And the results from this are very good, and most people with a low-grade prostate cancer can safely go onto surveillance as an initial approach. Moving on to radiation therapy, I mentioned at the beginning that we've made big improvements in the survival of prostate cancer, and we've made big improvements in the technology by which we can deliver radiation therapy. So back before I was practicing in the 80s, radiotherapy was very rudimentary and was planned only on X-rays. We didn't have 3D information, we only had 2D information. And it meant that we treated more of the tissues around the prostate, and the dose that we could give to the prostate was lower, so the cure rates were lower. Over time, we've improved our technology, our imaging and our treatment machines, which have allowed us to deliver more shaped radiation fields. So you can see on the right that the radiation dose is now customised around the prostate gland. And we can make the treatment even more accurate. So the little picture down in the bottom corner with the 3 gold seeds, the 3 little dots, that's an X-ray of where the prostate is. And those little dots are 3 gold seeds inside the prostate gland. So we can take a picture of that every day before treatment, see exactly where the prostate is, and make sure that our radiation is very, very accurate. The one that looks like the little map of Australia, with the bright spot where Sydney is, that's an MRI picture of the prostate showing us where the cancer is. So one of the things we can do now is we treat the whole prostate gland, but we can also give a little bit of extra radiation, which we call a boost, to where we think the problem area is, again, to increase that dose and increase the likelihood of curing the cancer. So what all of this has meant over time is that we've increased the dose, we've increased the likelihood of curing the cancer, and we've decreased the chance of side effects by making the radiation treat less of the normal tissues around the prostate gland. What we've also been able to do because of these technological advancements is in some cases, not all cases, decrease the number of treatments that are required for radiation. So still now, but for all people in the past, often a standard course of radiation was 39 to 40 treatments given over 8 weeks. Again, because of big clinical trials that were done, we now know that for some men, particularly men with intermediate risk prostate cancer, we can very safely give the treatment as 20 treatments over 4 weeks. So that's a big difference. We've halved the number of treatments, but getting the same outcomes, no increase in side effects. It's not suitable for everyone, but it is an option for some people. And what we're looking at now is actually bringing the number of treatments down even further. So there have been studies looking at what we call stereotactic prostate radiation, which is where we can give between 5 and 7 treatments of radiation, usually over 2 weeks, using lots of our technology. And we've got early results which look promising, but we still need more information from clinical trials and longer term results. But that is something that's likely to be coming down the pipeline fairly soon. And we did participate in a trial in Australia called the SPARK trial, which was looking at stereotactic prostate radiation in Australia. And this used a technology where we were able to monitor the exact position of the prostate while the radiation beam was on. And you can see that we're live tracking the prostate, which is the little red dots on the screen, and we can see if it's going off course, and then we turn off the radiation beam. So we can make it very accurate now. Radical prostatectomy is, of course, the other standard treatment for prostate cancer, and outcomes have also improved for radical prostatectomy over the past 10 years. One of the big changes has been the introduction of robotic prostatectomy, but it's important to know that the cure rates are very much the same whether you have an open or a robotic prostatectomy. There are some small improvements that are available with a robotic prostatectomy, but really the most important factor with surgery is that you've got a good surgeon who's experienced in that technique. And that's the most important thing. So anyone who has or would be considering having open surgery, you're not getting an inferior treatment. What you just want is a good surgeon who's good at that technique. It's not politically correct to talk about Lance Armstrong anymore, but his book was called It's Not About the Bike. You want Lance on the bike, but not when he was cheating. So it's about the operator is the point. So that's surgery, and you get very good results with surgery as well. Another example, similar to active surveillance of when less is more, is the use of radiation after prostate surgery. Now, this is hot off the press. This was presented at the big American radiation oncology meeting 2 days ago. This was an Australian study, and it really is a world first, of comparing radiation given immediately after surgery versus watching and waiting and giving radiation later on if the PSA was increasing. And I'm just going to go through this quickly because we need to get to some other stuff. But basically what this trial showed was that you had equivalent outcomes whether or not you used radiation up front or you only used it down the track if you needed it. So this is a good thing because it means that we don't have to use radiation for everyone after surgery if there are high-risk features, but that we can safely monitor that and only use the radiation if it's needed. And that means that we decrease unnecessary side effects. So this is a great result. The other thing that this showed was that salvage radiotherapy, given if a PSA is rising after surgery, was very effective when it's given early. So that's also fantastic. One of the other main treatments for prostate cancer is hormone therapy or androgen deprivation therapy. And this is treatment which lowers the testosterone. And prostate cancer needs testosterone to grow. So if you take away the testosterone, you're kind of like starving the prostate cancer and putting it to sleep. And this was first discovered by a gentleman called Charles Huggins in 1940s, so a long time ago. And he actually won the Nobel Prize for it in 1966 or so. So this is actually really one of the first targeted therapies for prostate cancer. Hormone therapy is used both in the curative setting, so we often combine it with radiation to get the best outcomes, and it's also used for metastatic prostate cancer, which is spread, or for cancer which has come back after previous treatment. Now, hormone therapy is very effective, but it also does have some side effects related to low testosterone levels. And this lists some of the side effects that can happen from prostate cancer. And Rob Newton is going to be talking later, and he'll be talking about the benefits of exercise. And as Tony mentioned, or Jeff mentioned, taking control of your health is something that's very important. And exercise is one of the things that has so many benefits, both in terms of mitigating side effects from hormone treatment, but also seems to have some potential benefits in terms of the actual cancer itself. But Rob will go through that in much more detail down the track. So there's quite a few things that you can do to minimise some of the side effects of hormone treatment, to keep the body healthy and strong, but exercise is really the key there. Now, with prostate cancer which is spread, which we'd refer to as metastatic prostate cancer, historically ADT was the main treatment that we had, and then so it would be lifelong treatment with hormone injections. And it really was in around 2004 that there were studies showing that a chemotherapy called docetaxel improved survival when it was added to hormone therapy once the cancer had become resistant to the hormone treatment. So later on, not at the beginning. So in 2004, we showed that there was a benefit for docetaxel for prostate cancer which was not responding to hormone treatment. And then later on, we developed some more hormone tablets which are better and stronger and more targeted, which also improved outcomes. And then the biggest change that we've made was actually not a new medication, but actually just changing the timing of when the docetaxel chemotherapy is given. So in the past, we used to give it later on, but a big study from the UK showed that if you give docetaxel chemotherapy up front when someone first presents with metastatic prostate cancer, that significantly improves survival by over a year. And that's probably one of the biggest improvements that we've made in prostate cancer in the past 5 years, simply moving the timing earlier. So now, particularly if it's a higher volume prostate cancer, chemotherapy may be offered up front together with hormone therapy. And just recently, we've also found the same thing for these other new hormone tablets. Enzalutamide is an anti-androgen, so it blocks testosterone from getting to the cancer cell. And an Australian study called ENZARAD, led by ANZUP, was recently presented in June this year, and it showed that giving enzalutamide together with hormone therapy for newly diagnosed metastatic prostate cancer improves survival. And this was an international trial led by Australia, which is fantastic. Similar results for abiraterone, which is another hormone tablet, and another one called apalutamide. So what's fantastic is that we now have multiple treatment options for prostate cancer, whereas 10 years ago we had one. So this is fantastic. Another one called darolutamide. Having all of these things is fantastic, but then this raises more questions. Which one do we use first? How do we combine them? And we're still in the early phases of figuring that out, but it's good to have options. The other big change that has happened for metastatic prostate cancer is the concept of treating the prostate in the setting of metastatic disease. So historically, we've always thought that once the cancer has escaped from the prostate, local treatments don't really have a big role. You need a medical treatment which is treating the whole body, but surgery and radiation can only treat one area, and if you can't treat it all, that there probably isn't benefit from having radiation or surgery. But what we've found recently, from a big study in the UK called Stampede, is that by treating the prostate with radiation for men with metastatic prostate cancer, but particularly in the group who only have a small number of metastatic spots, so less than 3 or 4, that treatment to the prostate, improves survival. So this is a big change as well. There are studies looking at whether or not surgery would provide the same benefit, but currently, in a lot of the guidelines, it's now been updated that if someone presenting with newly diagnosed metastatic prostate cancer with less than 3 to 4 spots, that radiation to the prostate is something that is a reasonable option to consider. Down the track, there's lots of other medications that we now have for prostate cancer. There's other chemotherapy like cabazitaxel. There is radium-223. I won't talk about radium-223 because Louise Emmett, who's a nuclear medicine physician, will probably go through that this afternoon. But the important thing to take home from this slide is that 10 years ago we had very little. We had hormone therapy, and now we have so many different medicines and options, radiation, targeted therapies that we can use for prostate cancer and at different times to extend survival. And what we really now need to figure out is who needs which treatment and in which order and in which combinations we should use them. I'll skip that one. Another important thing with prostate cancer is that we look after the bones, both because hormone treatment can make the bones a bit weaker over time by having low testosterone, so it can increase the risk of osteoporosis. But if cancer does spread, the bone is a common site where it may travel to. So we do have medicines that can decrease what's called skeletal-related events, which is basically bone problems, bone pain, fractures. So there are a couple of medications which can strengthen the bone and make the bone a less hospitable place for a cancer cell to travel to and grow. So it's kind of like making the soil not very friendly. So we've got medications called bisphosphonates, and there are 2 options for that. And then there's also a newer medication called denosumab, which you might have heard of the names of Prolia or Xgeva. And they have roles for prostate cancer in terms of keeping the bones strong and healthy. But again, what else helps the bones? Exercise. Now, external beam radiation is also a very good palliative treatment for bone metastases if they're causing pain in the bone. Let's skip that one. Ongoing clinical trials. There are lots of things that are being evaluated to continue to improve treatment. Immunotherapy is of course of interest. It's shown promise in other cancers. As yet we haven't had significantly good results in prostate cancer, but we're still doing trials and working out how we might make prostate cancer more responsive to immunotherapy. And another interesting area of research is PARP inhibitors, which are medications looking at targeting prostate cancers which have alterations in the capacity to repair DNA. So lots of trials for us to go with moving forward. Where can you find information out about clinical trials? So these are 3 websites that you can go to. So the ANZUP website, which is the Australian New Zealand Urogenital and Prostate Clinical Trials Group, is great. There is actually an Australian government, Australian Cancer Trials website where there are search functions where you can look for what trials are available, and TROG is our radiation group, so they all have information about what trials are available in Australia, but probably the first step is always talking to your doctor. So that's it from me. So now it's over to you. What would you like to see happening in the future?
Big clap.